All right. Hi, everyone. My name is Kylie Hall. I work at North Dakota State University in the Center for Immunization Research and Education, and I am going to be your moderator for this session with Dr. Mark Strand. Dr. Mark Strand is a professor in the School of Pharmacy and the Masters of Public Health program at North Dakota State University. His current research focuses on the epidemiology of chronic diseases. He is currently active in research on opioid misuse prevention in community pharmacies, and that is funded by the North Dakota Department of Human Services. I do have to read this disclosure. Dr. Strand has indicated that this presentation will not include discussion of any commercial products or services and will not include any discussion of off-label and/or investigational uses of any product or services and will not include trade names. So Dr. Strand, you can go ahead and get started. I will just mention to everyone the pre-test link has been put in the chat box. Please make sure you take that before Dr. Strand starts. So go ahead, Dr. Strand.
Okay, well, thank you everybody, and appreciate the opportunity to share on this important topic of public health ethics during this unique time in our state's history, having just come really toward the end of the COVID experience. Public health as a profession tends to do its job in the background without demanding attention or praise. COVID-19 has brought public health into the public's eye in new ways. In full public view, COVID-19 has taken lives, overburdened healthcare systems, forced closures, and exacerbated existing inequities. But what has been completely unexpected is the degree to which COVID-19 and our response to it has elicited misunderstanding and outright derision of public health by some in our community. Why is this? Has our community always had an indifferent attitude toward public health, or is it something about COVID? Many of you work in frontline local public health, and I'd invite you to consider this question as I go through my presentation today, because I believe this is an opportunity for the public to understand what public health is and how it works in order to achieve the government mandate, which is given to us by the Constitution, which is to provide for the welfare of the general public. Now, here are my learning objectives then today. So talk about our response here in North Dakota. I'm going to explain the 12 principles of the practice of public health, and then explain the relationship between ethics and our response in North Dakota. As I said, COVID-19 has revealed that the public largely doesn't understand or necessarily trust the role of public health in protecting the health of communities when it involves some implementation of mitigation measures. These measures are perceived by the public as a nuisance at best and a violation of their individual freedom at worst. Unfortunately, this has resulted in differing opinions about the appropriateness of the measures used, and in some cases in negative actions directed toward public health departments and individuals working there. The upshot of this is that it has raised the ire of enough states' legislators that at least 15 states have passed or are considering measures to limit the legal authority of public health agencies to protect the public from harm. This includes legislation in North Dakota denying the governor and the state health officer the authority to enforce a statewide mask mandate in any future respiratory infectious disease outbreak. There's also banning of quarantines in Montana, blocking of business closures to prevent super spreader events in Kansas, the setting of arbitrary limits for how long emergency orders can be in place in Florida, and giving unilateral authority to legislators to stop public health actions in the state of Ohio. So here in North Dakota, we had an event in Minot where the Minot Public Health Administrator, or the First District Health Administrator, Lisa Clute, was supposed to give an update on the pandemic to the City Council. And at that time, one of their council members Carrie Evans promoted that they implement a mask mandate, which Fargo had done that same day, which led to one of the other council members who disagreed vehemently with what was being said. In fact, he made this comment. He said to Lisa, "We don't need to slow the spread. We need to have health organizations throw spaghetti noodles at the wall for a cure until a treatment comes, until one of them sticks." He then pointed out that his physician friend had told him, "Tom, if you get COVID, take 220 milligrams of zinc and drink a gallon of tonic water for 2 days and that will clear it up." And this was the kind of events that were happening around our state. This is one of the many incidences that began a very difficult time for our local public health leaders and administrators. So while local public health professionals were not surprised by the virological perspective of COVID-19, I don't think we were totally prepared to be bullied and inundated with the flood of misinformation that we received. Now, lest we begin to pity ourselves, this response to public health mitigation measures is not new. In 1918, when San Francisco's epidemic spiked back in the Spanish flu, a second time in January, officials issued a second mask mandate order, but this resulted in protests, vehement protests. An anti-mask league formed, packing an auditorium to listen to speeches on how to fight the ordinance. In nearby Oakland, a prominent physician said, if a caveman should appear, he would think the masked citizens are lunatics. So this is not new. This has been something that has been difficult to implement way back to the 1918 and 19 flu. And yet in comparison, at that time, national unity was high and trust in science was high compared to today. What is different today is the amplification effect of social media and the way in which public health has become heavily politicized. In 1918, arguments over the closures revolved around questions of efficacy, equity, and the duration of the measure. But in contrast, today, views of public health and even science have been heavily influenced by partisan views. Now, these negative reactions stem in part from a fundamental misunderstanding of public health, including a misunderstanding of the ethics which underlie public health as a profession. And in this presentation, I would like to introduce the 12 principles of public health with application to our current COVID experience. These 12 principles, I'll go through all 12, land on 4 a little bit, and then I'd like to develop 2 at some length. And by the way, these were updated in 2019, but the principles remain largely the same. So the principles of ethical practices of public health, and I hope you put on your thinking caps and try and ask yourself, how have we performed in each of these ethical principles during COVID? So number 1, public health should address principally the fundamental causes of disease and requirements for health, aiming to prevent adverse health outcomes. Now, why is it so difficult to focus on prevention? It seems as if we were unwilling to wait until COVID deaths mounted to start to respond. Rather, we should have been using available data and prior experience with infectious disease outbreaks to anticipate the trajectory of the epidemic and to proactively mitigate its speed and severity. However, many leaders didn't allow public health professionals to provide that kind of guidance, so that although we had cases in the US beginning as early as January 21st in such far-reaching regions as California, Chicago, Arizona, and Washington, we didn't issue a national emergency and begin prevention measures until March 13th. So I think here we wanted to act locally, but we were often not allowed to. The second principle of ethical practice is that the public health should achieve community health in a way that respects the rights of individuals in the community. This is one of the 2 I'd like to spend more time on, so I'm going to put that one off for now. The third, public health policies, programs, and priorities should be developed and evaluated through processes that ensure an opportunity for input from community members. So I'd like you to consider, what have we been doing during COVID to get input from community members? This input happens in public forums, the media, city council meetings, and others. And I think we probably could have done better, but we were so overwhelmed by the tasks at hand that it was hard to seek input from the communities. Perhaps this also speaks to the issue of the relationship between public health agency leaders and their supervising government officials over them, in that more participation could have been solicited. So our performance in each of these ethical principles is a function to some extent of how our local leaders view us. Number 4, public health should advocate and work for the empowerment of disenfranchised community members, aiming to ensure that the basic resources and conditions necessary for health are accessible to all. You know, this is why residents of assisted living facilities, minority populations, working as CNAs and essential workers, and individuals working in cramped quarters, this is why we went to great lengths to try and protect those persons, because that's an ethical practice of public health. We identified this concern early on and had some success. In fact, one of my students who's from Nepal was able to provide tremendous support to the Nepali community in their own language to understand issues regarding COVID. Number 5, public health should seek the information needed to implement effective policies and programs to promote and protect health. And then number 6, these two are similar. Public health institutions should provide communities with the information they have that is needed for decisions on policies or programs. So these two are number 5, we need to seek the information and the data that we need. And number 6, we want to provide that information so that people can make decisions and form policies. This speaks to the need for real-time data collection. I would say our state health department did a fine job in creating our COVID dashboard, in holding daily press conferences with the governor himself present every day for a long period of time. And then getting that COVID epidemiologic data out to the public, I think we did well. However, I do feel like the COVID-19 health metric that we used in the state was created with insufficient input from public health scientists and therefore was insufficiently rigorous. It relied on 3 measures used equally weighted. One was the active cases per 10,000. The other was the number of tests performed per 10,000. And finally was the percent positivity rate, all of these on a 14-day rolling average. But testing is a fungible indicator, and it's a function of how much effort we're putting in. So the more you test, the more you find. And then the more you test, the lower the positivity rate. So, but they aren't really direct indicators of the severity of the outbreak. And so I think that forced us to be in a situation where we underappraised the severity of the pandemic, and thus our response was a bit too late. And this resulted in a 3-month delay in elevating our risk level, where it should have been elevated to moderate risk on July 1st. It was not until October 16th. And so, I think also in regards to mask mandates and other mitigation measures, by pushing it down to the community level, we really neglected our duty to provide vision, both the data and the assistance to make those decisions from a position of strong leadership, so that people were left kind of struggling. I know from my own perspective, I was helping my church manage how to respond to COVID, but I had to rely on Minnesota's faith community guidelines and webinars, because here in North Dakota, I was a bit left up to congregations, were a bit left up to their own decisions. So we had the necessary information, but it wasn't provided to communities, small communities like say a church, or larger communities like cities and counties. It wasn't provided to them in such a way that they were able to really make the best decisions. So that's numbers 5 and 6, getting at that data and then providing it in a way that communities can use it. Public health ethical principle number 7, public health institutions should act in a timely manner on the information that they have with the resources. Now, not only in North Dakota, but across the country, we seem to be more responsive to medical emergencies. So if we have increase in deaths, or if we have increase in, hospitals being overburdened where they don't have enough beds or enough respirators or enough personal protective equipment, these are medical emergencies that elicit action in our country. But those were all things that could be anticipated from a public health perspective, but we didn't really have that kind of response. We had lots of data from, Italy and other places that we could have used to help anticipate how things would go, but we were a bit delayed in that response. So in contrast, being more familiar with these types of infectious disease outbreaks, many African countries took quick action even before they had their first case. And until now, many of those countries have largely avoided a serious COVID pandemic or epidemic in their countries. So I hope that public health will become more empowered in our willingness. There's number 7, I'm sorry, I forgot to advance. I hope public health will become more empowered in our willingness to act in a timely manner. But unfortunately, we don't have a great history here. If you think about our country, it often takes a decade for us to take necessary action. And if you're not confident that my assertion is true, just think for a moment about air quality control measures in the 1970s and the AIDS struggles of the 1980s and tobacco control struggles in the 1990s and cardiovascular disease prevention measures in the 2000s. and then the opioid and hepatitis C co-epidemics of the 2010s, in order to us to be true to our code of ethics, we need to be able to act in a timely manner and not wait until these public health crises only become a medical crises. Now, our vaccine production has been fantastic and record-setting in its pace and in its rollout, and we celebrate that. So we do want to also acknowledge that we've definitely acted in a timely manner in some aspects in our response. I'm also wanting to just share a few thoughts on how, the notion of having things pushed down like to the lowest level of decision making. This is a political philosophy to push things down to the lowest level. However, this assumes that individuals will be able to make a lot of personal decisions on their own in the best interests of their neighbors. Now, I don't doubt at all that North Dakotans truly love their neighbors as themselves, or love their communities and are willing to sacrifice for their communities. And we see this all across our state when there's an illness or an injury with somebody and the neighbors come together to support that person. So I have no doubt about that. But I'm not persuaded that with COVID, most individuals or small communities were able to comprehend really what types of behavior would put their neighbors most at risk. And thus we're in a difficult position to know, how do I best love my neighbor as myself? And now we've seen with Health Bill 1323 forbidding the governor and the state health officer from issuing a mask mandate in the future. This is going to be problematic because it assumes that the lowest level of society is able to make those decisions. But since 1911, during the pneumonic plague in Manchuria, we've known that facial protection is the best and cheapest way and most least societally disruptive way to prevent respiratory disease outbreaks. In fact, in the last year or so, using nationwide data, researchers Leo and Wiebe showed a statistically significant decline in new cases of COVID up to 21 days after a state mask mandate was put in place. And this is nationwide data. In contrast, employee-only face mask measures resulted in no change over 21 days. Van Dyke et al. In a MMWR report from the CDC reported on Kansas, where the governor put in place a mask mandate on July 1st, 2020, but counties were allowed to opt out of that. So it was a natural experiment where they could compare within Kansas those counties that opted out from those who respected the governor's mask mandate. And as you would expect, trend analysis for a 7-day rolling average showed daily increases in all counties prior to the mask mandate. And then after the governor's mandate, they split. So those who had a mask mandate, it began to decrease consistently over the next 7 weeks. And those who opted out of his mask mandate, the numbers continued to increase for the next 7 weeks. For we know that viruses move regionally and rapidly, and mitigation is only effective when it happens in a strong and coordinated manner from the level of authority that is appropriate to the size of the region impacted. So if you have a statewide outbreak, then it has to be coordinated at a statewide level. And if it's a nationwide outbreak, it has to be coordinated at the nationwide level. This is because viruses and the humans who carry them move around freely. So if you have a mask mandate in one business, but the one across the street doesn't, if the virus is passing across that street, then it's not going to be effective for that one business who has a mask mandate. And similarly, if two neighboring communities like Fargo and Moorhead, or Mandan and Bismarck, if one has a mask mandate and the other doesn't, the virus wins. And similarly, neighboring states. So we have to consider the notion of pushing these decisions down to the lowest level, the risk that presents. Using Google's community mobility report data set, researchers Wu et al. Have shown that changes in mobility were in response to federal guidelines, not to local policies. So people in a given state responded to what the federal government was saying about social distancing and were less sensitive to what was being told to them at a local level. So the lower down you push decision making, the more difficult it is for those individuals to have the expertise to be able to make those difficult decisions and handle that epidemiologic data and make complex decisions. Furthermore, at that lower level, if the authorities above them aren't making that decision, how can their own local community trust that their decision is a good one? So they're going to get a lot of kickback. So I believe it's important for us to consider, both now and in the future, timely response to epidemics and managing them at the highest level necessary according to the geographical space within which the virus is moving. Okay, number 8, public health programs and policies should incorporate a variety of approaches that anticipate and respect diverse values, beliefs, and cultures. Now, time forbids me to dive into this principle, but I refer you to Chrissy Gerard's talk here in just a bit on health equity, and Olehi Okoro's talk on racism as a public health problem Friday morning. Number 9, public health programs and policies should be implemented in a manner that most enhances the physical and social environment. Number 10, public health institutions should protect the confidentiality of information that can bring harm to an individual or community if made public. So I'm going to skip over these now because they are less pertinent to the topic, but I do want you to consider all 12 ethical principles. Number 11, public health institutions should ensure the professional competence of their employees. And you may know that I'm teaching in the Master of Public Health program here at NDSU, and you have opportunities to increase your professional competence at your local public health unit. And we hope that we and UND are able to provide courses and certificates and degrees that can help continue to increase the public health capacity of our state. And then number 12, public health institutions and their employees should engage in collaborations and affiliations in ways that build the public's trust in the institution's effectiveness. Now, the issue of the public's trust is really important moving forward. So I'm going to push number 12 to the end of my talk, and I'll unpack that. But first, I'd like to come back to number 2, which is the issue of public health should achieve community health in a way that respects the rights of individuals. I think this is where we've been most understood by our communities. During the COVID-19 pandemic, our leaders have been challenged like never before to strike the balance between protecting the community while respecting the rights of individuals. The rapidly changing and tumultuous circumstances of a pandemic make this extremely challenging. Now, during the COVID pandemic, public health leaders have nobly protected the health of the public through implementation of COVID transmission and mitigation measures while striving to respect the rights of individuals. But what has been lost on many people is the consideration that the rights of individuals is not synonymous with unlimited freedom. The ethical principle of protecting the community is built upon the principle of interdependence, which teaches that all the members of a community are dependent on one another for the common good, and that no single individual is an autonomous agent with unlimited freedom. Part of the problem, I think, lies with people confusing medical ethics with public health ethics. With medical ethics, the priority is on the autonomy of the individual or the patient first, and it focuses on their individual needs and their choices. However, to ensure the common good and during a pandemic, elected officials have to make difficult decisions to protect the entire public and to ensure the provision of the common good. But to do so cannot simultaneously confer unlimited autonomy upon every individual. That's not to say that individuals don't have any say in their decisions that these officials make, nor that their individual needs are not considered. And that's, the number 2, that's exactly, what it says, that we respect the rights of individuals while we achieve this community health. And in fact, principle number 3 goes on to say that we seek input from the community members through public hearings and other ways so the community is able to give input to their public leaders. But at the end of the day, the public needs to accept that the public health officials are trying to do what's best for the majority. Now, in the short run, it may not feel that way, but in the long run, these measures are also in the best interests of the individual. For the suppression of the pandemic and the minimization of morbidity and mortality resulting from it are simply pathways to a return to normalcy and a recovered economy. Public health officials strive to implement mitigation measures that are effective in protecting the community while minimizing the negative effects on individuals. In so doing, public health officials are striving for mitigation measures that are proportional to the magnitude of the harm to be prevented. So the magnitude of the harm that might come from having to grind through 18 months of uncertainty justifies the same magnitude of lockdown necessary in the short run. This is in order to shrink the height of the epidemic peak, that's the so-called flattening the curve, in order to reduce the burden of disease and to shorten the duration or the length of time that the pandemic rages in order to reduce it to, in our case, hopefully less than 18 months. Now, if this can be accomplished, then the stringent mitigation measures implemented early are justified. And I think from our own experience here in our country, we have seen that the balance that has been struck was probably insufficient. And excessive concern for the individual needs and premature lifting of certain measures contributed to the prolongation and intensification of the pandemic, including many lost lives. This means the public needs to accept decisions made for the common good, and to do so shows their participation in the community struggle by making those individual sacrifices. That some in our country consider mask wearing to be a substantial sacrifice and a violation of individual liberty is sad. And perhaps it reflects a new set of values, I'm not sure. Or maybe it's an old issue with a new twist. French philosopher Alexis de Tocqueville, who wrote the book Democracy in America after his tour of America in 1831, sang the praises of America at that time. However, even then, he was concerned that excessive individualism in the US would result in people not being willing to work for the common good. So this is not a new issue in our country. Now, we know that these, individual rights are a part of what's created our society, and nobody wants to trammel them. But in a crisis, we have to consider the needs of the common good. Wearing a mask is done largely in service of protecting those who are vulnerable to the worst COVID outcomes, and that would be ethical principle number 4. And furthermore, I would suggest that sacrificing individual liberty for community benefit, even though it isn't one's personal preference, is the reflection of true virtue, whether that virtue is explained in humanistic terms or in faith terms. Some people crying out for individual liberty argue that elitist public health professionals don't understand the plight of the community. So apparently we in public health sit in luxurious quarters implementing onerous mandates that make other people's lives harder, but they don't affect us. But I don't accept this assertion. We live in the same communities that those in our community whom we're trying to protect live. Our elders live in the same assisted living facilities as theirs do. Our underlying medical conditions are just as vulnerable as the next person, and our desire for normalcy is no less. And the losses that we have experienced in our children's lives or in our parents' lives are no less significant than those whom we're trying to protect. The difference is being beholden to these public health ethical principles. We have a genuine vision for the common good, and we accept the same measures ourselves that we're asking the public to respect. Now, I do empathize with the classic North Dakotan mentality. I was raised in North Dakota, and I highly value the character and the virtues of the people of our state. Many of these individuals are living essentially in frontier communities, which is defined as individuals with communities with a population of less than 6 persons per square mile. And research has shown that opposition to mitigation measures was directly proportional to the degree to which a person was living in these so-called frontier communities. And so I understand that rugged individualism in these types of communities is conducive to innovation and resilience. But during this crisis, it has contributed to opposition to certain public health principles, according to Samuel Bazzi, economist from University of San Diego. And so I sympathize with the North Dakota culture of individualism and rugged, perseverance, but it has made it difficult to implement some mitigation measures. Public health is not trying to trammel on individual rights when they implement a public-focused mitigation measure, but simply striking the balance between individual and community needs. And in so doing is striving to exemplify the principle of proportionality, which simply means that we minimize the burdens imposed on individuals while imposing certain mitigation measures. That is, there is a sense of mutual aid or reciprocity that we're striving for. And it's not done excessively or onerously. Now, complaints that COVID-19 mitigation measures violated individual liberties, again, it was not unique to 2020, 2021. In 1918, there were similar protests against mitigation measures and lawsuits as well. The difference is that in 1919, the lawsuits were focused on how they, how long they would have these measures in place and things like that. Whereas today, the legal challenges are really fundamentally challenging the right of public health agencies to have authority. In 1918, legal challenges never contended that state or federal constitutions prevented regulators from intervening to slow the spread of the flu. Because at that time, these police powers were so ingrained in our society because they had faced so many epidemics and people realized how important it was for the common good. But in 2020, in contrast, we have filed hundreds of constitutional challenges to pandemic regulations, and a number of them across the country have been successful. In 1919, Isaiah Berlin published an important book called 4 Essays on Liberty, where he distinguished two different types of freedom: negative freedom and positive freedom. Negative freedom is freedom from interference and constraint, freedom from tyranny and coercion. Negative freedom assures people will be unrestrained in pursuing the negative influence of others. This is the type of freedom that many people wanted when they cried out for individual freedom during COVID-19, where they consider masks and shelter-in-place orders and business closures as a violation of individual freedom. But left unchecked, this can lead to an excessive autonomy and lack of a unifying vision for all of society, because each individual has their own definition of what's best. Now, on the other hand, Berlin talked about positive freedom, which is a freedom for those things which are excellent, according to whatever vision or whatever ideals you define to be excellent. This is a freedom to follow noble, protective, and aspirational leadership. It's the freedom to limit one's visits to the nursing home in order to protect elderly residents, the freedom to wear a mask in order to truly love one's neighbor as oneself, the freedom to agree as a community that it's best to move worship services online in order to stay unified while protecting the vulnerable. The challenge is that positive freedom requires outstanding leaders that can cast and form such a vision and then win the communities following. And we've seen this beautifully depicted in many places around the world. I think New Zealand under Prime Minister Jacinda Ardern and Germany under Angela Merkel was quite impressive. And we also have seen it in our own state with examples of this type of visionary leadership at times. So while human flourishing requires an appropriate balance of both negative freedom and positive freedom, during the COVID-19 experience, we needed more examples of positive freedom. The final thing I'd like to talk about here is number 12, which is building the public's trust, because I think it is an opportunity waiting for us in the years to come. How could we have better built, earned the trust of the public, and what can we do now? I just have a few thoughts as I conclude. I think we could have better considered our shared interests with the public earlier on. We could have better honored ethical principle number 3 by seeking input from community members in not whether to have mitigation measures, but how to do it, and how to do it in a way that was optimal and as less burdensome as possible. Secondly, as public health scientists, we could have been more upfront, where the public was hearing from us directly to get ahead of the misinformation that was so common in social media platforms. We could have demanded a place at the mayor's press conferences and be a part of the decision-making events over a given topic, because we needed, in order to be able to apply what we have and to call for evidence-based, nonpartisan responses to COVID-19. We could have engaged with the community as allies better. Credibility isn't only an issue of your expertise or how many initials you have behind your name, but credibility is also a function of how much those whom you're over perceive you as sharing in their interests and values. And I think that's an area where we could have done better, but it's not too late. There are still many things we could do to build the trust of our communities, our counties, our state. I think we can increase communication with community members regarding vaccine efficacy and vaccine delivery issues. I think we could consider having community events to celebrate coming out over COVID-19. And we could also strengthen social solidarity by bringing together community members to debrief lessons learned during COVID. How could we do better next time? And then to share that information with the rest of the community. Today, I've introduced the 12 principles of ethical practice of public health with some reflections on their implications during COVID-19. I've tried to do this in a way, one, to help ourselves think through why did we run into some misunderstandings with the public? And it has to do with the fact that we were trying to honor our ethical principles, but they were perhaps at times misunderstood by the public. I'm also sharing these 12 principles as a chance to reconsider whether we could have done better in some aspects. So in conclusion, the science of public health and the ethical principles of public health provide needed guidance to respond in a pandemic and to carry out our mission to protect the public and prevent disease. Included in this is the ability to balance the needs of the public with individual preferences and individual rights. In North Dakota, the public's response to COVID-19 mitigation measures was largely supportive, but it was also vociferously opposed by a vocal minority of persons. The 12 ethical principles of public health are a helpful guide to keep our work on track, particularly when public health emergencies arise and when public misunderstandings increase. The 12 ethical principles keep us true to our mission to promote health and to prevent disease and keep us true to the code of ethics. Thank you to all of you who have been representing public health over the last 15 months. And while you may have faced a lot of challenges and even misunderstanding, you have carried out your mission and served the people of North Dakota with honor. Thank you.
Thank you, Dr. Strand. That was wonderful. Before we get to questions, I do want to remind everybody that I have posted post-test evaluation information in the chat box. So if you're seeking continuing education credits, please make sure you take those. Does anybody have any questions for Dr. Strand? I think I have a quick question for you, Dr. Strand. So in thinking about, the last year and the ethical principles that you talked about, I'm wondering how best we could have addressed all of the misinformation that was out there. So whether it be on social media, whether it was coming from, White House press conferences, how best do public health officials address that and keep their constituents' trust when they're hearing something different from another place?
Yeah, that's a really important but a very difficult question. I think it would be particularly with regard to ethical principle number 3. If we had formed a coalition of faith leaders, and if local public health would meet with those faith leaders every couple of weeks to just answer questions and provide information, and then it could be, local educators, could be another, affiliation group. So I think we were just so overwhelmed with tasks. It was hard to do that, getting input from the community and hearing what their issues were, because I think a lot of that misinformation, if we tried to take it on with our authoritative and maybe so-called our perception of correct information, it's not going to change the thinking of a lot of those people. However, their affinity groups, those that they respect or those that they connect with, would be potentially more influential. So I think that communication with local community organizations or community leaders probably could have been done better.
That really piggybacks off a question that was just asked by Sharon in the chat. Can you please identify 2 of the biggest changes you would have made at the beginning of COVID so that a better job could have been done?
Yeah, I think perhaps local public health leaders at the county and then regional and even state level to really insist that they be at every table, every decision-making table. I think about my Fargo City Commission. I know they were getting information from the local COVID, response team, But it's one thing to be able to consult with a group. It's another thing to have somebody at the table. So I think public health maybe was maybe reluctant to, insert themselves into those decision-making bodies. Again, the communication piece too, I think, more and more proactive communication early and often, to piggyback on what the governor did and what the state did, would be another area that I would probably have said we could have perhaps done better.
Mm-hmm. Mm-hmm. Yeah, well, I do want to make sure that we stay on time. It is 2:30. I think I really like Debbie's comment here in the chat. She says she thinks constantly about how a mask requirement in our state at an earlier point might have saved many lives. And we need to do a better job of articulating the ethics behind decision making. So, Dr. Strand, I want to thank you for taking time out of your busy schedule to present for us today.